Thank you for that very enlightening session. Without much ado, let's move on to the next session. Ending our day with controversies in critical care, I'd like to call upon our Chief Moderator, Dr. Varun Bhairappa, intensivist and head of ICU at KIMS Bengaluru. And our chairpersons for this session would be the man who needs no introduction, Dr. Rajesh Mishra, consultant intensivist, Ahmedabad, Kyati Multi-Speciality Hospital, Ahmedabad, Dr. Ratan Kumar Gupta, senior consultant, adult intensive care at Narayana Institute of Cardiac Sciences, Dr. Satyajit VK, intensivist, Melbourne, Australia, Dr. Somnath Chatterjee, consultant anesthesia and intensive care at Prakriya Hospitals. I welcome all the chairpersons onto the dais.
Okay, welcome all. So we're going with the first topic. So the first topic is end-of-life care, current understanding in the Indian context. And I welcome Dr. Shiv Kumar Iyer on dais.
Thank you very much for inviting me to this edition of the Global Intensive Care Symposium 2024. I'm honored to be here. Just a little addition to my introduction. I'm also head of the Department of Critical Care Medicine at the Bharati Vidyapeeth, deemed to be University Medical College. So today I'm going to take you through end-of-life care, current understanding, an overview of the legal, ethical, and cultural dimensions of decision making. So briefly, I'll take you through the historical background, then a brief look at the exploration of goals of care, breaking bad news and principles of good communication, what an advanced medical directive means, what is palliative care needs assessment and when should it be done, what is the role of triage, admission discharge criteria to ICU in the context of EOLC, what is the role of a family meeting? What does a time-limited trial mean? And then finally, a brief look at guidelines for withdrawal of therapy. So I think it was George Santayana who said, those who forget history are likely to condemn to repeat it. This professional development in end-of-life care has a long history. Way back in 2005, the Indian Society of Critical Care Medicine published its first guidelines of end-of-life care, and that paved the way for several iterations of these ISCCM end-of-life care guidelines. In 2014, we partnered with the Indian Association of Palliative Care, and we published what was known as the Integrated Care Plan for the Dying. And, we also had a ISCCM campaign that year, which was called Together We Care, along with the Indian Association of Palliative Care. 2016, NABH standards for EOLC were published. A year before that, the ISCCM, the IAPC, and the Indian Academy of Neurology, they came together to form an end-of-life in India task force called ELICIT. And this ELICIT was instrumental in advocacy throughout the country. And this advocacy and moving from place to place was what resulted in these NABH standards for EOLC. Then in 2018, ELICIT, the three societies involved in it, and the ICMR came out with this definitions involved in the limitation of care and palliative care document, and it has come to be a landmark paper which has clarified our understanding of the terms involved in end-of-life care. Then in 2019, we came together with the Industries Federation in India. Elicit came together with them and published this guide for patients, administrators, and hospitals. In 2020, we had further draft guidelines with the ICMR. The DNAR paper got published. The advanced care directives and withholding-withdrawing therapy, however, still remain as draft guidelines. Along with this professional development and the advocacy meant that we worked along with the lawyers and the legal community. So soon following our 2005 guidelines, we had this 196 Law Commission report called the Care of the Terminally Ill. This was authored by Justice Jagannath Rao, and it was an excellent initial Law Commission report. In 2011, there was the Aruna Shanbag judgment of a lady nurse who was in a persistent vegetative state after suffering a murderous assault and rape. And she was in the KEM Hospital Mumbai wards for close to 35-40 years. And the question was whether her feeding tube could be withdrawn. And for the first time, the court acknowledged that withdrawal of therapy may be done. Unfortunately, they used a term called passive euthanasia, which is no longer in use. Following this, there was the 241st Law Commission report by Justice Reddy, which incorporated the findings from the Aruna Shanbag judgment. In 2014, following this 241st Law Commission report, the Supreme Court issued a notice to union territories on the plea to legalize euthanasia. That's what they called it. But what they actually meant was withholding and withdrawing therapy. And this was in response to public interest litigation by a company called Common Cause. Prashant Bhushan, previously of the Aam Aadmi Party, a prominent advocate from Delhi, was the one who filed this public interest litigation. He said that my mother is in the ICU and doctors, she's not going to live, she's going to die, but the doctors are not willing to withdraw the ventilator. And so he had put up this PIL. Following this, there was a draft bill called the Care of the Terminally Ill Patients, which the government had put on the website, inviting public comments. Nothing happened after that, not a priority really for the government. Then in 2018, and I would regard this as a game changer, the Supreme Court judgment called the Common Cause versus Union of India was published, in which Justice Deepak Mishra, who was the Chief Justice at that time, said that the right to die with dignity is on an equal base with the right to liberty and life in Article 21 of the Constitution. Because of certain cumbersome procedures in the 2018 judgment, the ISCCM had put forth a clarification petition for the Supreme Court judgment, and this final judgment was given in 2023. And following this, we had the publishing of the 2024 ISCCM guidelines, which is the latest iteration of the end-of-life care guidelines in our country. Okay, now I'm not going to really tell you any more data, but we're going to go through a case which I hope will explain the current understanding of ULC in the Indian context. So a 49-year-old lady was diagnosed to have interstitial lung disease 2 years back. Let us imagine that you are the respiratory physician who diagnosed the ILD 2 years back. So what are your thoughts on managing this patient? I'm not sure there are very many, are there any chest physicians or physicians who practice as well in the community? I can see a few hands go up. So if I were to ask what you would do, apart from doing a biopsy and diagnosing the condition, starting the immunomodulatory or immunosuppressive treatment, if the condition worsens, then seeing if a lung transplant would be feasible. Apart from that, what else should you do? So the answer is something which is actually very clear, but it is something which Probably none of us do. Exploring the goals of care at an early stage when a chronic illness is diagnosed is an extremely important step. And as physicians, we are very bad at this. So this mnemonic is my own, 5 E's of the principles of communication. So the first is to establish rapport with the patients and family. This is done by setting aside enough time in a quiet place, make introductions, do good nonverbal communication, find out what the patients are feeling, thinking, their families feeling, thinking, what the kind of rapport is between them. The next point is about exploring the level of understanding. And exploring the level of understanding always starts with open-ended questions. These open-ended questions can then, through a reflective approach, lead to directed questions. And that's the way you explore the level of understanding. Language that we use must be simple. It must avoid medical jargon. And all of us get pretty adept at medicalese. And this medicalese is something which we fall back on when we feel threatened. And therefore, it's very important for us to be comfortable and calm during family meetings. The language should be culturally appropriate. It should not be threatening. And it should be non-confrontational. In examining the comprehension of the situation that patients and families have, using the ask, tell, ask principle is very important. So first you ask what the patient knows. Then you clarify, you tell them what you need to tell them. And then you ask them again whether they have understood what you have told them. So ask, tell, ask is an important principle. And all through the process of examining the comprehension of situation, it is important to be mindful of emotions. And the nurse mnemonic is very useful for this. And finally, you should end with a summary and further plan. So this is the nurse mnemonic, and you can see that it's naming, understanding, respect, support, and exploring. So naming the emotion, some people in this situation would be upset rather than saying, I can see that you're angry, which might elicit further anger, is very important. Understanding and appreciating what the family is experiencing. I cannot begin to imagine what you must be going through. Showing respect need not just be verbal, but it also may be non-verbal. So active listening kind of demeanor is very useful from the treating physician or the person who's communicating. Supporting them through the entire conversation, very important. And then exploring what people are feeling through open-ended questions is extremely important. So much about communication. Let's go ahead with the case. So I feel that communication is central. And whenever we start, we must always start by communicating well. The case went ahead, and now in the last 2 months, her symptoms have significantly worsened, for which she has been put on home oxygen therapy. The patient has decided that she wants to change her physician as she was not feeling better. So doctor shopping, which is very common in our setting. And now she has come to you for a second opinion. Again, I'm not sure that there are very many people in the audience who, but I feel that it is part of advocacy for us as intensive care physicians to advocate with our treating consultants and physicians who admit patients in our ICUs. So what are your thoughts on managing this patient now? So what would you like to do? She's worsened now and probably has now developed significant palliative care needs. Let us say that there are no options really for transplantation or for any other therapies. So at this point, we must make sure that we help the patients with terminal illness to do advanced care planning. So you can see how advanced care planning progresses. So initially, patient establishes care. That was 2 years back. Healthcare provider A has talked about serious illness. Then this patient now has progressed, is now requiring home oxygen therapy. Now there's healthcare provider B. And between these two people, they are going to explain about serious illness, organ failure, terminal illness, and also explore frailty. In the initial stage, what we do is an advanced care directive. Later, what we do is withholding or withdrawing therapy. So an advanced medical directive, so this is from the Pallium India website. It's a very nice draft advanced medical care directive. And I think many of us should think of telling our patients to do this. In fact, convincing our fellow physicians who are not working in the ICU to explore this and to advocate for doing this. I think having advanced medical directives will make looking after patients who come with acute and chronic illness to the ICU, make this much easier. So you can see here that the first requirement is that it is made by the person, and he's a person of sound mind with full decision-making capacity, and it is being done without any coercion of his own free will. And when is it being done? When the stage of terminal illness and he goes into a coma with no reasonable expectation of regaining consciousness, or has a disease state from which I have no reasonable expectation of recovering with an acceptable quality of life. So like in this case, the patient with terminal interstitial lung disease who is developing increasing need for oxygen therapy, or having reached a persistent vegetative state with no reasonable expectation of regaining significant cognitive functioning. So this comes in next. And then these following steps are taken. And you can see that what you would want or what you would not want is mentioned on the advance directive. And then finally, surrogate decision maker is mentioned, and the document is completed with signatures and being notarized by, previously it was a district magistrate, now it can be simply notarized or by a gazetted officer. Next, she is presented with severe breathlessness to the emergency room and was put on NIV. You've got a call from the emergency department of your hospital. So how will you go ahead? Assessing palliative care needs in the emergency department or within 24 hours of admission, looking at presence of chronic illness, of multiple admissions in the last year, significant caregiver distress, multiple admissions, and the surprise question, would you be surprised if the patient dies in the next 1 year, are very important in assessing these needs. Anyway, she was admitted in the wards for NIV for 2 days. She was not settling down. At this stage, having good triage criteria and admission discharge criteria for ICU would help, and it would help us to discover at this stage that patient is not going to benefit from life-sustaining therapy. Anyway, that does not happen. The Code Blue team has intubated the patient, and patient is shifted to ICU. Last 3 days, she has developed VAP and multi-organ failure. How will you proceed? So doing a family meeting, giving a time-limited trial would help. Now the family has reached the end of the road. They don't have money. They're emotionally exhausted, and they want to take the patient off the ventilator and take her home. So what will you do? So these guidelines for withdrawal for therapy have been published on the Ministry of Health and Family Welfare site. Comments have been invited from all concerned people. So I would urge all of you all to do this. This is the withdrawal of life support in terminally ill patients from the recent guidelines. We did a public consultation on this last Sunday on the guidelines which are on the website. Since I'm out of time, I've come to my last slide, and even in the quotes, what I would like to leave you with is that I think we are suffering from a deficit of compassion and kindness. And so therefore, bravery is the courage to be able to live in this world without any deception and with tremendous kindness and caring for others. And so that will lead us to take good decisions for our families, to focus on what their needs are and on the ethics of the situation, rather than worry about the law and worry about ourselves. Thank you so much.
Thank you, Dr. Shivkumar, for this wonderful presentation. Next, I would like to welcome Dr. Jacob Verkis to talk on donation after circulatory death, and is India ready for it? I welcome you, sir.
Good evening, everyone. Thank you, JIG's team, for inviting me. Thank you, chairpersons. Evening time, I know to talk after my own teacher and examiner, I told Shiva ISR is going to be difficult because he takes a crowd in a spellbound situation. So my topic is a pretty different one. What about donation after circulatory death? Is our country ready for it? Now, if you look at the scenario, this is from the Global Observatory of Donation and Transplantation data. India performs the third highest number of organ transplantation after US and China, more than 15,000 in 2022. Most of these are living donor kidney and, living donor kidney and liver transplantations. Only 20% are the disease transplant, donor transplantation in this. This accounts for only 10 transplants per million population in comparison to US, which is around 100 transplant the disease donor transplantation. And it is less than 5% requirement what we normally have in our country regarding the organ pool. Even though it is going up, but it is still very less when you have the deceased donor transplantation. So when you talk about a disease organ donor transplantation, all of you know that the brainstem death is confirmed. You call it, you are the process and protocols are very clear. And that particular thing is termed new as DNDD. That means donation after neurological determination of death. Similarly, the death happens not only because of brain death, death happens because of circulatory arrest also. So this particular donation which happens after circulatory death is now termed as donation after circulatory determination of death, also called as DCDD. And the DNDD, the brain death donation, has got fair protocols and policies developed, and all of us are sitting in this room are almost clear about these things. And the retrieval of organs and the quality maintenance is at par with any other thing in the world. But mind it, the brainstem death constitutes only 1 to 2% of the deaths. All of us face circulatory death as more common in our ICUs. So the challenges when you talk about donation with DCDD, that means determination of donation after circulatory determination of death, is that the percentage is going to be very high. And in DNDD, neurological determination of brainstem death, it is authorized, planned in advance so that the protocols are in place. Whereas in DCDD, the circulatory death, the donation needs to be authorized when the death is anticipated, which is going to be real troublesome because it causes ethical, legal, economic, procedural, and logistic challenges of all people, all of us sitting in this room. So in a nutshell, what is DCDD means that in circulatory death, when somebody comes in circulatory failure, we start CPR. If you attain ROIC, well and good, the ROIC and the care continues. But if the ROIC is not attained after 30 minutes, CPR is deemed as unsuccessful and the death is certified. Suppose if the patient has got an unsuccessful resuscitation, then with regards to DCDD, how do you put the term is that you try to procure the organs rapidly after circulatory death, or you re-establish a perfusion by some certain means, and then it can be used for DCDD transplantation. Also, we can add upon one more thing. Forget about the death. What if somebody's life, the life-supporting treatment is futile, or we are considering withholding a life-sustaining therapy? This is a condition where we can plan a donation after circulatory declaration of death when there is a withholding or withholding therapy is being planned in your unit. Moving forward, but it is not easy. There are certain classifications for DCDD in our country, which is across worldwide. What commonly used is a modified Maastricht classification. There are 5 scenarios. Of these, 3 are uncontrolled, 2 are controlled. Uncontrolled means that somebody from the community developing a cardiac arrest come to the ER, not having any pulse or breathing, and you're declaring his death on arrival. This is uncontrolled. Second uncontrolled one is came in cardiac arrest, you resuscitate, not able to resuscitate. Third uncontrolled is in an ICU patient where active treatment is going on, an unexpected cardiac arrest. These 3 are an uncontrolled situation, happens mainly in an ER or an ICU. 2 controlled situation is that you have a patient who is very sick, life-sustaining treatment is futile, cardiac arrest is anticipated. That is a controlled one. And in a brain-dead patient, you are contemplating transplant, he developed a cardiac arrest. This is a control. So Maastricht classification holds good for DCDD. It has got 3 uncontrolled and 2 controlled scenarios, which is based on the circumstances. Category 3, that means the anticipated cardiac arrest, which all of us face in the ICU, is one thing which can constitute 90% of what is called as the donation after circulatory determination of death. So what are the procedures and protocols you follow? Certain things are very important. For ethical reasons, the determination of futility and withholding life-sustaining treatment decisions are completely delinked and insulated from decisions about organ donation because to avoid any conflict of interest and loss of trust. Similarly, if the family brings up the topic of organ donation in a patient who is sick, the treatment protocols, what they're giving is futile, and you're contemplating what is called as the withholding life-sustaining therapy. If the family brings up because of an altruistic intention, make sure that you defer it for a later date till you reaches a stage where a consensus is reached for the WLCT. Now, if you have a controlled DCDD, the category 3, where a sick anticipated cardiac arrest is in the ICU, you sign withholding life-sustaining therapy treatment, and you have the protocol which has been placed recently with Supreme Court, the primary medical board, the secondary medical board. Once it has been signed, you withdraw the aggressive measures, you extubate the patient, wean off the supports, and the patient started dropping in pressures, where the systolic BP drops less than 80, and patient reached a stage of asystole, where all of us declare the death. However, when you are contemplating a DCDD or a donation after circulatory death, there's a time called as no-touch period for 5 minutes. The 5 minutes you allow, no intervention should happen to that particular patient. This is the time for family to present probably, and the death is determined after 5 minutes. Again, the 5 minutes, if blood supply is not in the brain, it's going to be irreversible damage. So after the no-touch period of 5 minutes, the death is determined. That is the time you'd start organ preservation technique and organ retrieval. This is purely, it's important because the warm ischemic time, the time to retrieve the organ, there is a time for the organ quality. So it starts from the time the asystole is there. So if you have a category 3 control patient, which I already mentioned, an anticipated cardiac arrest, and already the family has agreed for withholding of life-sustaining therapy, this is a group of patient you can consider going for a donation after circulatory death, and this is a protocol you follow. Mind it, the organ retrieval is only performed after the 5 minutes of no-touch period, which is a very important aspect if you're contemplating a donation after circulatory death. Suppose you talk about category 1, 3, and 4, where it is uncontrolled. From community, patient is coming to the ER, you do CPR, in cardiac arrest, you do CPR, not revivable. A patient who is in the ICU is an unexpected cardiac arrest reviving. So this is an unexpected or uncontrolled event. You have a cardiac death, you have an asystole. If any discussion regarding a circulatory death donation is happening, again, the protocol after that remains the same. You have a 5 minutes of no-touch period, death determination, then organ preservation and retrieval technique happens. Most important thing is that family who are inclined for organ donation are explained about the procedure, the timing and location of withdrawing of life-sustaining therapy. Sometimes, if you are planning a donation after circulatory death, sometimes the WLCT, the withdrawal should happen in the theater because of rapidly procuring the organs. Consent for antemortem measures. You may have to do some antemortem measures like heparinization to prevent the organ from getting ischemic. And the no-touch period, what is that? Explain properly. And you also explain the possibility of a stand-down. Stand-down means that sometimes how much ever you try to procure the organs after the family consent and after the particular protocols, you may not be able to get the organ because the ischemic time may elapse much more than what you expected. So then the patient gets back to the ICU and continue with the end-of-life care scenarios. So for the organ retrieval and preservations, there are certain measures, if the law allows, you can consider antemortem by putting a femoral cannula and giving heparinization. Now, once the consent has been approved for WLCT, once the consent has been taken for organ donation, the protocol I'll come to later, then the measures has to be started immediately because the extubation happens, the patient develops an asystole. After the no-touch period, you start the procedure of procuring the organs, which the main important point is that the warm ischemic time, which starts from your asystole, or the functional warm ischemic time, which starts from your systolic BP, is very important because if it crosses the time, then the standoff phenomenon happens, you may not be able to retrieve the organs. So all the protocols and policies which we follow for a WLCT has to be followed up, where the care futility is explained properly, patient values and wishes has been addressed, withholding and sustained treatment, the place protocol should be mentioned, and controlled determination of death by circulatory criteria, what I mentioned earlier, then your organ retrieval and preservation and organ-specific target things start here. So before going into that, this is the one thing which Sir mentions earlier. WLCT, the withdrawal life-sustaining therapy, stands a cornerstone. And this is the current guidelines where the determinants of futility care has been mentioned. The hospital constitutes the primary medical board. It approves the futility of care. Secondary medical board, again the thing continues, and the treating team discusses with the family, surrogate decision makers, or any one of them. Then the WLCT is being signed. So once that is been informed the judicial magistrate, then if there is an understanding for a determination donation after circulatory death, the treating team informs the transplant coordinator. The transplant coordinator with the team discusses the same issue what is discussed about organ procurement to the healthcare, to the surrogate decision makers, and then the team performs the withdrawing life-sustaining therapy and organ is retrieved. The area of retrieval can be either in the ICU, most commonly the WLCT happens in the ICU, so OR also can be considered because of rapid recovery of organs. Now, how do you recover the organs? Now, there are multiple measures of recovering it. Suppose the arrest happens or the WCT happens in the ICU, quickly move the patient to the theater with CPR or without CPR. And there are certain measures we can rapid recovery of organs by immediately opening up the thoracoabdominal area, perfusing the femoral lines, do heparinization, do the cold techniques to preserve the organs and remove it. The other important step, the new current development is what is called as the NRP, or the normothermic regional perfusion. Again, you put cannulas to the femoral, to the IVC, and you start giving the blood or the saline or the whole saline to make sure the organs are safe. And most important thing is that you cut off the brain. You will not give a supply to the brain because already it's a brain dead patient. So this is a NRP has been reasonably accepted and reasonably gaining a lot of importance. We can either can do an abdominal NRP for procuring kidneys, liver, and other things, or you can get thoracoabdominal if you're planning for a cardiac transplantation. Ex vivo machine perfusion, again, a latest development where there's hypothermic machine perfusion or a normothermic machine perfusion. Hypothermic machine perfusion is by giving cold saline and other things. Normothermic machine perfusion is by giving blood and other blood-like products. So this is some things which we like to maintain. But the logistics and the techniques to procure these organs needs a lot of challenges and a lot of expertise to coordinate everything, availability of the surgeon, availability of the organ receiving patient. So these things needs a lot of refinement and things to go on. So in world, if you ask what is the world data, the Christian Barnard performed the first cardiac transplant. It was not a brain dead patient. It was a heart taken from a circulatory patient who had died of circulatory death. Similarly, globally, in Western European and non-European countries, especially US, China, and Spain, the number of DCDD, that means donation after circulatory death, is tremendously increasing because the brain death patient pool may not be enough to fulfill the demand for the organ requirement what is there. In India also, there are published report which this is Ahmedabad hospital data where they 2019 and 2012, they did 10% of the disease renal transplantation were from the DCDD pattern. And the graft function or the renal, the recovery rates or the functionality of the kidneys were not very bad compared to normal thing. Again, this is another from the PGI Chandigarh study where 5 to 10 donors, they have taken, and with CPR, they shifted the patient after circulatory arrest to the theater, and organs have been procured. And the graft function may not not very bad compared to the recovery of the grafts are pretty good. So this is possible. So what is the unique challenges we face in our country? The problem is that the lack of awareness of EOLC, palliative care, and withdrawal life support. That is the first thing which we change. Most of the clinicians may not be aware of what is a good EOLC, when do you plan it, and how do you plan it properly. And lack of understanding, reluctance of organ donation is value to society. And we have a lot of lamas and damas. By lamas and damas, everything is in compromise. The patient is not getting dignity of death, and families' opportunity of donating organs has been linked. And also, it is important that in India, organ donation is linked to brain death. So circulatory death is also a situation where the patient life doesn't exist. So organ donation needs to be linked with that one also, which will take us forward. The way forward, the first thing is to make sure that the Supreme Court judgment for 2023 needs to be optimized, needs to be done properly in all the ICUs. Once the withdrawal of life-sustaining therapy become common practice, my feeling is that the controlled determination of death, donation after circulatory determination of death may be possible. And you can start it in a few transplant centers and refine the protocol over the years, create SOPs, and implement it in a proper way and register it so that it can be used for other things. Is India ready for it? I think it is possible in India because we have high demand of organs and our donor pool is very less. WHO statement in 2022 says that you need to be self-sufficient in organ donation in every country. And DCDD, the circulatory death is an acceptable pathway for organ donation in India because apart from brain death, circulatory death is also considered as the Transplantation of Organs Act as physically the patient doesn't exist. So the role of intensive is going to be huge because we form the central line where the withdrawal lysosine therapy is happening. So our policies and protocols, what we create and we type with the families, and our awareness to the families and things makes very, very important role in continuing or in taking it forward, the circulatory death donation to the next level. My references are from the papers, which is from the ISACM and certain articles, which has got a lot of ICU, our colleagues as an authors. And August 13 is an World Organ Donation Day. People who doesn't know that, this time the theme is that be the reason for someone's smile today. So my dear friends, circulatory deaths and organ donation after circulatory death in India, a long way forward, but it is feasible and intensivists like us play a major role. Thank you so much for a patient hearing.
Thank you, Dr. Jacob Varghese, for making it very clear. So now we go to the next topic. I would invite Dr. Rajesh Mishra on stage. He's going to talk on Government of India definition of intensivist, the controversies surrounding it.
So, good evening and thank you for the opportunity. And I'm really happy and amazed to see that at the end of the session also, there are so many people in the hall. So it's really commendable. So I've been asked to talk on one of the very controversial topic. I hang around controversy. And my disclaimer is whatever I'm saying, this controversy came because I run a group where around 600 people around the world are there. And they had a very strong opinion when the definition of intensivist was given by Government of India, which was suggested by some of our colleagues. So whatever I'm saying, I'm just trying to give you opinion what general public thought of. Before that, I just want to give you information. When I was president of ISCCM, one of the very important, maybe few people did not like, but majority did like, and majority of people used to say me, okay, Rajesh, this post-MBBS certificate course is definitely diluting intensivist position and should be stopped from ISCCM. So EC agreed to that and we took that decision to stop post-MBBS certification course and AGM passed that. And probably that may be the reason that why Pradeep has asked me to talk on this topic. So let us see what Government of India definition says about intensivist. It says that intensivist, when you say you are intensivist, you should be having training, certification, and hands-on experience in managing critically ill patients with an ICU, with a background degree of postgraduate degree in internal medicine, anesthesia, pulmonary and emergency medicine, or general surgery. Fine enough. I'm not able to understand. Either you need to standardize something. You are generalizing. You should have a training also, and then you have a baseline degree. And it doesn't stop there. It doesn't stop. It comes further. Let me ask you, how many, don't know, I know that there is a time when people got expert just by getting trained themselves, but trained changed. How many of you are going to get yourself operated by a neurosurgeon who has not done MCH, who is just trained as a neurosurgeon, and somebody says he's a good neurosurgeon? How many of you are going to get yourself operated by a cardiac surgeon who has not done any, do not have a proper degree? Somebody says, I'm a good cardiac surgeon, I'm trained in this institute, that's why I'm a cardiac surgeon. You need to have some certification which is standardized. Unfortunately for intensivists, maybe because of demand, which people argue, maybe because nobody wants to leave their patient, everybody became intensivist, including Ayurvedic doctor who has working in ICU, including post-MBBS who has done 1, 2 or 3 year course. That's what it says. Now, over and above, you are saying in addition to baseline degree, you should have DM degree. Why it could not have been a very straightforward that you should have a super specialty degree if you are considering yourself super specialist in this whatever specialty you come, like If you are a cardiologist, you have done DM in cardiology and get yourself trained in cardiology. If you are a neurologist, you have done DM or DNB in whatever degree is recognized. So why it is so much of the variation that right from the MBBS training certificate, or not only MBBS, if you see further, that you have been even done a training under a society recognized course. I do not have any problem with that. But why so much of heterogeneity and equivalence? And if it is there, how will you standardize the process? There should be some standardization. And that's why controversy came, that you are making everybody intensivist who has worked 6 months in ICU, who has worked 3 months in ICU, who has worked in 1 year, because he said, I have experience after MBBS, and as per this, I can become intensivist, so I am calling. What is it doing? It has two problems. One, is definitely is not providing an equivalence of care, definitely is not providing a standard of care, it's compromising care, and at the end of the day, it's costing a life. We cannot expect, intensive care is not that easy, that everybody just after doing MBBS observing that how I am setting ventilator, and he sees 6 months and after just put somebody on ventilator and he understands that way. It took really a lot of time. And in fact, you are one person as an intensivist who has to take care of every complication, right from the surgical to medical to post-transplant to immunocompromised, everybody. And you think that after MBBS, just doing 1 year observer certificate, you can become intensivist. This is something which is non-acceptable, and that was another controversy. This it was said, alternatively a minimum of 1 year training in a reputable ICU is also okay, you can become. Reputable? What is the definition of reputable? How can you say this one reputed and this one not reputed? In current time, everybody is saying, I am reputed, I am doing this one, I am doing this one. So a lot of jargon word has been used in this definition, and that is creating problem, and that was the controversy, that thing. So I personally feel that by diluting ourselves and by by just giving, okay, you work here, you become intensivist, I'm making it so generalized, probably we are creating a fleet of the doctors who probably do not have a basic understanding, who may know, you have to put arterial line, who may know how to intubate, but do they really understand the basics of critical care? Are they able to solve the complex problem when they come across? I'm not very sure they are, and that's one of the challenge, and that challenge we have started facing when a patient come from them to us, how the basic mismanagement has been done. We should not say, but everybody of us are facing that problem, and probably somewhere we are responsible for it, what we have created about it. Now, over and above, you are saying that if you have an MBBS degree, even if you are giving a 1 year job, we have done in critical care, and then 50% time if you are giving intensivist, you can become intensivist. What is the fun? One, you have done MBBS, done 1 or 2 year observer training, and then only 50% you give, then you become intensivist. At least some standardization, sometime. You cannot equalize a postgraduate super specialist with the same qualification. That was another thing which was probably problem. Probably we have made it very easy and non-serious by doing this. So the main concern was, after all this definition came, can a person with basic degree, 1 year observership, 2 year observership, is equivalent to MD or DM, DNB? Can he perform same way? Can he provide same quality of care? Can outcome will be same in the ICU? Can he become good team leader? Has he given enough time to understand what critical is all about? Probably no specialty. No specialty has diluted the critical care the way we have. Even people have, there are other super specialist society, but nobody has, they have their courses only to assist. Like suppose you are a DM cardiologist. If you want to electrophysiologist, we do 1 year course. After super specialist you do. But here what we have done, just basic degree, because we wanted to fill up the gap. So we created a fleet where anybody can become intensivist. And probably somewhere this was one thing which was hurting a lot of people for care, and that's where we took that decision. So the second, another thing was patient care. Can they provide? Probably not. So the argument given by people who said that we want post MBBS or maybe basic degree with 1 year or 2 year courses, that we do not have enough workforce. Probably that is not the solution. No specialty again has done. Every super specialty has a lack of expertise. We do not have enough cardiologists. We do not have even enough physicians to peripheral area. But nobody has taken this shortcut, which that just by observation, you give a certificate that you have worked under this and you become intensivist. Probably this was something which was compromising a lot as a specialty, and for this, somewhere or other, we have to pay the price for not providing proper care to the patient. That's what my thought. I may be wrong or thing. So what can be done to have a proper intensive care? Whatever we want to do, at least there should be standardization. Like this should be your minimum training. Like if you want to neurosurgeon after MBBS, you go for 5-year training and then you become neurosurgeon. So NGX does 5-year training after MBBS, then people become critical care. Nobody can become critical care expert. You should be allowed that if you are taking it seriously, that after 2-year theory, you are allowed to become critical care. So there should be uniform certification, uniform standardization of care, and there should be a well-structured course which everybody should know that much, and then you should call intensivist, and even that should be our aim. So with this, thank you for your attention. I do not have much to say, but I hope I have tried to convey what I was asked to.
Thank you, Dr. Rajesh Mishra. Now we'll be going to the. You want to have a discussion? No, not really. We'll go to the debate. We'll go to the research in critical care. Are we just reinventing the wheel? By Dr. Venkat Raman Kola, who will be talking pro. If there are any questions for the first 3 speakers, we can take 1 or 2 questions for just a minute or so.
We will have the discussions at the end, sir. We'll continue with the tri-bait for now.
Okay, fine. Yeah.
Yeah, thank you, Jix, and good afternoon, Bangalore. So I will be talking about, are we reinventing the wheel again in the critical care? So in the last 3 decades, from my intensive care qualification, we had RCTs, meta-analysis, systemic reviews, but I have not seen majority of them have no therapeutic benefits or interventions which are discovered and available. No long-term benefits, pendulum effects, study says yes, no, go on, inconsistent literature evidence. Many of the literature says this is a positive trial, we later on find to be negative. Research in critical care happened in this list of areas, including sepsis, ARDS, and rest all. But for an intensivist, the 2 common syndromes which actually took the center stage is sepsis and ARDS. I will take through some of those researchers which actually has taken a whole wheel or a pendulum. These are the list of things, except those basic things which were there 30, 40 years back, like early antimicrobial therapy, source control, maintain perfusion. The rest all, which were given in the last 3 decades, has not shown to be beneficial. If you start with early gold therapy, 2001, we were talking about a targeted goals to actually achieve to help our septic patient. Later on, those who have been proven to be not beneficial. So we are back to the same. Activated protein C, one of the therapeutic agents which has shown to be having some mortality benefit, has taken into the coffin. Metabolic resuscitation in 2017 with this Paul Marik paper has given a reignition. But later, further, we have seen that it not just helps, but that high dose of vitamin C can actually harm your patient. So it has been taken into the desk, taken out of the desk. Steroids, what to say about steroids? From my medical school days, we have been seeing steroids, yes, no, doses, and been different places. And extracorporeal blood purification. When we were postgraduates, we were told extracorporeal can be a way forward in the septic patient. If you look at initial few studies, has some promising results. Later on, it was been discarded, and we have no literature evidence supporting it. Many drugs, including ulinastatin, has been dumped, saying yes, initially there were some case series, but in a large trials, it could not prove anything. Volume, restrictive, liberal, initial restrictive, later liberal, now total initially, as for the individualization, all that kept on going. albumin, a colloid, which has been in place, initially said there is no difference between 4% albumin along with your crystalloids. Later on, there were subgroups which were suggesting that albumin can be a way forward as a colloid in a special subset of population. Novel vasopressors, angiotensin 2 has been came as a backup, saying that when your noradrenaline, adrenaline is not work, angiotensin 2 can be an answer, but later on it found to be not useful. Tight glycemic control. We've all been considered that glycemic control has been very irregular in your ICUs to be tight. Later on, we found that is actually taking more lives than required in medical ICU. It probably may be helpful in a very specific where we are not working. Immune nutrition has been a lot of hype in the past, but as you go forward, it not only helps, it is talking about harming the patients in the later studies. So we have discussed it. Biomarkers, CRP, procalcitonin, TREM3, many, but at this point of time, if my register asks me what is the role of a biomarker, I just confine it to say probably de-escalation or discontinuation, neither for diagnosis, neither to prognosticate. So coming to the second syndrome, ARDS. Yes, a couple of things, low tidal volume proning has shown to be some effectiveness, but rest all, if you see, it swings the pendulum in one or the other way. Either you take muscle relaxant or steroids. This is the first study where we talk about neuromuscular blockade in accuracy showed that it will help in mortality and also taking out the ventilator if you paralyze these patients for initial 3 to 4 days. But later on, we realized that sedation is equivalent to those who are adequate sedation is equivalent to those who are paralyzed, and again in the Rose and Patel group. So the wheel kept on rotating. Steroids, there is no exception to this in ARDS. There are medullary group which actually always proves to be steroids are useful. We have many groups which suggest steroids are not useful, in fact harm. And recruitment and optimal PEEP. I think my senior colleague will have a talk tomorrow on both of this, but we still are debating what is the optimal PEEP, how do we get there, and recruitment. And this particular trial by art groups talks about probably generalizing recruitment, generalizing titration of PEEP, probably not helpful. So where do we be there? ECMO in ARDS patients. So we had a seizure trial which suggests there will be some benefit to them, but later on in 2018, again, EOLA trial talks about probably there is no gross benefit in them. Fluids, we've been talking about initially crystalloids, then said there are a series of colloids. And then we are talking about, again, no colloids, only crystalloid. There were debates about only colloid of albumin and which type, whether it is a normal saline or a balanced salt solution, what amount of fluid in the initial resuscitation is still on, go on debating. We have a series of actually the crystalloid-based studies which suggesting only one thing, probably hyperchloremia is harmful. This we know long back, hyperchloremia is harmful. But that's after a series of things we are talking about. It's not normal saline, it's not balanced salt solution, it is hyperchloremia. We all are aware of it. And renal replacement therapy. We were talking about early, late, and we are debated in many trials. We are talking about different modalities, different doses. If you look at all these studies, none of them could conclude we were all doing it late, and they were saying, okay, probably that may be a right way. And different modalities. We could not prove one modality is better than other. And at the end, even the doses have been debatable areas. And the different multicentric studies talking about earlier, we used to avoid early calories, high low calories. Later we were told, no, full calories and calories should be achieved in a quick time. But later we realized hypocaloric diet, early part, day 1, day 2, probably helping us. So again, we were doing the same thing. When somebody is not well, probably we were going slow. To conclude, probably I will talk about 3 things which actually changed my mind. We are rotating around the wheel. Forget about the bundle care we were debating. Capillary refill time. Way back, long story. Our pediatrician, our physicians at the hometown, we were doing this. Now, after this Andromeda trial, we are talking about probably it's equivalent to a lactate. Is this not the reinventing the same wheel again after probably a few decades? This is again very interesting thing. a web bundle. We have been told that oral care with a chlorhexidine probably is the way forward. Look at this new study which are talking about chlorhexidine oral care kills patients. Stop it. Probably the guidelines suggest change it to regular oral care. Oh my God, the whole blood. We were told whole blood is not the way to go. It has to be a component. Look at this paper. This paper talks about from American college that probably fresh whole blood is the way forward in a trauma resuscitation patient. To conclude my debate, I put forward my senior colleague, intelligent colleague who is in the bedside. We were talking about whenever we actually deal a patient, we talk about individualizing each patient at the bedside and take a decision. What we were doing 30 years back, we were looking at the patient, we were deciding on the basis of the clinical situation. We were again talking about take clinical acumen into the account. We're talking about the clinical judgment into the account. Every conclusion of any conference, you say personalized care, individualized care, clinical acumen, clinical judgment, trajectory of your clinical course, then these are all there long back. What did we gain again with all these trials? So I put my debate saying that all these trials has taken a wheel across and we were in the same place. And I will rest my debate. Thank you.
Thank you, Dr. Venkat, to making it a heated debate. So I now invite on stage Dr. Suresh.
All right, thanks. I think it's interesting to see so many people, but I think I'll start the debate saying that Dr. Venkat didn't get didn't get the topic. I think he showed us a lot of negative trials and then why we should do. But I think let me just go ahead and clarify what we want to do. Just for curiosity, who invented the wheel? So that's good research. Nobody knows who invented it, isn't it? That's how research should be. It was done in Mesopotamia sometime back in 4000 BCE, but we really don't know who it is. So what does reinventing the wheel actually mean? It's an idiom. So it's like muhavra or whatever you want to call it. It means to describe the wasteful effort of setting out to do something or create something that already exists. Whatever my colleague showed you is great research, because it goes to prove a point that we don't have any truth. We really have to keep on digging to find out what is the truth. So reinventing the wheel is a phrase that all at this point in field, what he's asking is, just be a Dr. Suresh Ramasubban, just be at the bedside, not do anything else and do this. Has this already been? No. Reality is an illusion. If anybody hasn't seen Matrix, please. So reality is not is an illusion, and we really have to dig into it. But I'm going to debate on this issue by challenging various points. Why do we need to continue to do research? And why it is not reinventing the wheel when we don't know what is the actual truth? Point number one. We have to challenge and validate previous assumptions. So the assumptions, he has given all the examples for me. So research has in critical care medicine as a clinician, as we need to do in intensive care, is to revisit these paradigms. If you don't revisit the paradigms and agree that Proves was a success, we'll still continue to give activated protein C. Isn't it? So there are so many things that we have to do. We have to ensure that clinical practices remains evidence-based. So for example, the classical example is a blood glucose target. We have already talked about fluid therapy. We're going to talk about oxygen goals. I'm just going to look at these two great trials by Vandenberg's group from the Leuven-1 and Leuven-2 trials. So this would have made us believe that tight control of blood sugar, because the pathophysiological basis of hyperglycemia causing harm and the tight control of blood glucose in animal studies was so good and so dramatic that it is absolutely essential that we need to do this kind of a study. And so we should stop research at this point in time. Should we say that Leuven was absolutely fantastic, we should not do any more research, finish it off, and nothing else is needed? So we don't need to reinvent the wheel at all. We don't need to believe that, we need to believe that this is Satya, iske upar koi Satya Vachan nahi hai. Is it, what do you say, so the difference between science and religion is that, isn't it? You can question it. In religion, you can't question the holy books. In science, you can question the holy books, you can question Vandenberg and say, why did you come up with this thing? And you end up finding out So for all, anyway, if any students here, now the goals of blood glucose have changed dramatically. If you look at the YSEP data, which first said there is harm, then you look at the nice sugar, which says so much harm of blood sugars, and then you have so many this, and now we have the last study published in NEJM last year, which says now the goal of blood sugar is 215. No longer 140 to 180. We have liberated it even further. So 140 to 215 is the goal in 2014. So 2024, we continue to do research to come up with a point that yes, whatever goals we have set will change. So the number one thing is that we have to challenge and validate previous assumption. There is no assumption which is not there. If any of you haven't read this book called Nexus by Yuval Hari, should go ahead and do it, because this is the difference, as I said, and this is democracy. When you question what you are doing and you're doing it again and again, and you're doing it at any and every level, is what is democracy, and this is what is the difference between science and religion. So you have to challenge the pre-existing test, and you have to validate it, and you have to do it in the global display. If you look at all the DNB thesis that is presented, everything will be Eastern India, you know, in metropolis of Calcutta or something like that in Bangalore. Why do we do that? Why do we waste our time? Is it what my learned opponent is going to say? No, it is important. Research in critical care medicine has to address the inequalities that exist. If we were to believe that fluid therapy, if you were to believe that Baxter, that everybody has to give in 30 ml per kilogram of fluid bolus, you will not have a feast trial. You will not have a trial done in sub-Saharan Africa which tells you that fluid might be harmful if you don't have a ventilator. It might be harmful if you don't have monitoring. So we have to do these trials in sub-Saharan Africa. We have to do these trials in our country to prove that research is important. We have to do these things. So it is important to understand how we need to do it. And we have this modified ARDS definition. So where have all these come from? And you have to understand that my opponent, if you go to Yashoda Hospital and look at his studies, he points out that he has done research on co-investigator of low molecular weight heparin versus SCD. How many of you want to do that again? I can give you a meta-analysis of 7,000 patients which has done this already, but he is a co-investigator. Why is he reinventing the wheel? Because he believes that we need to do research. So this is his CV in from Yashoda Hospital. So please do not believe anything that my dear opponent has told you. We have to continue, we have to reinvent the wheel, otherwise it's not possible. Look at the modification, the Kigali modification of ARDS. Why do we do it? Because we need it in our country. Why do we need the feast trial? Because we know otherwise you're going to drown your patients thinking malaria, dengue is the same as everything else. So you got to do the research. You got to understand that. You got to learn from global disparities. Again, read this guy, Satnam Sanghera. He's an absolute fantastic guy to read if you want to understand how evil imperialism was. All right. So you will understand how colonialism has ruled our culture, our minds, and how we are still in the same mindset. How we need to think separately from globally. So we need to do research on our own. We can't accept whatever is given to us. So please do not stop reinventing the wheel just because a white man said so. All right. So that is reason number 2 that I would say that you should do it. And most important thing is what we say is improving patient outcomes through iterative improvements. Iteration means the repetition of a process. Repetition is the mother of learning and the father of boredom, which makes it the architect of success. This is quote by Dr. Suresh Ramasubban, modified from Zig Ziglar, who was considered one of the most important motivational speaker in the United States. He was a salesman. I have modified it to this thing. And so I find that repetition is the father of boredom, but it is also the mother of learning, and we cannot forget this. So iteration is very, very important in whatever we do. Whether we do it at the bedside, the capillary refill time is a good iteration. We have been doing it for again and again. And it is now, we understand that it's very, very important. Even in cases where research builds on existing knowledge, incremental advances have been found to have profound impact. Refinement in fluid management, all the studies that he showed you are actually improvements in what we have done. They are not negative trials. They are improvements in our understanding of what we know. So we need to do these research which might be negative trials. Just because there are negative trials doesn't mean that we stop in doing research. And that is very, very important. Ventilator management, sedation management, all these things have improved just because we've been able to reiterate and do iteration and do repetition of these things to say whether it works or not. Even as it is, minor changes may seem insignificant. He'll say it's a waste of money, waste of time, why do this? why is he investigating SCD versus low molecular weight heparin again? Why is he doing it? Because what does he want to achieve? He is reiterating things. These are the small things which are going to improve outcomes. If he were not to do that study, why does he put it on the Yashoda's website? Isn't it? So reiteration is absolutely important, and he has understood it. So it improves patient outcomes. It's going to decrease your ICU length of stay. It's going to decrease your mortality. These small increments are going to change a lot of things in our lives. So I'm going to stop here because I know I'm a little more, a minute in advance. I have another 3 sets of arguments that I can continue and give you many more points to say that research is something which we need to continue. It is not reinventing a wheel. A negative trial is not a negative connotation. So we need to understand that we're going to do 3 things that I have highlighted. I can highlight another 3 things and another 3 things if I have the whole day. But I'm going to stop here by saying what Dr. Devdutt Patnaik quotes in all his studies. Within infinite myths lies the eternal truth. Who sees it all? Varuna has but 1,000 eyes. Indra 100, you and me only 2. So to question the eternal truth and to find the eternal truth is the purpose of research. Please continue doing research. Please do not listen to Dr. Venkatraman Kola, because he is going to stop you from doing good things in life. Thank you very much.
Thank you. Both the doctors with the pro-con debate have raised the bars. So we request Dr. Anirban to consolidate it and have some take-home messages.
Good evening. It was nice to hear both the learned friends speaking pro and con against a subject in which it was a game of guesswork and scientific evidence both, which they presented wisely with some deficiency in wisdom. So that makes the job of clinical equipoise important. The term equipoise was first used by Benjamin Friedman because he said that in order to compare any randomized control trial between 2 arms, there should be some amount of uncertainties. Without uncertainty, there can't be research. And if we look into the perspectives of healthcare, it is always fraught with uncertainties. There cannot be a healthcare where there are no uncertainties, because the entire conundrum of processes, the informations, the stack hole of experiments, and the impressions gathered through the continuous research are dwelling in controversies. And whenever there are controversies, uncertainties creep from all directions. It is not possible to count them. They can be in the measurements, they can be in the form of missing data, they can be in the uncertainty in the medical treatment, they can be in the form of incorrect diagnosis. Therefore, if we look into the technological advancements, there is no doubt that unforeseen advancements in technology has been the hallmark of critical care. Even a cursory look at the ventilator evolution during ages, forget about all other monitors, ECMO, Plex, blah, blah, blah. Even a cursory look will give you enough evidence that there is no need to argue over it. But is technological advancement only the research? No. Had it been so, we would not have entered into that stage where we would have been having an argument over whether it is about reinventing the wheel or not. If we look into Dhanvantari, who is considered as a form of incarnation of Lord Vishnu, who is worshipped as the god of medicine, you will have he is having his entire scripture in one hand and an insect in the other hand. So if we leave the scripture and start discussing on the insect and try to find out the correlation, what it might have on the medicine, that is useless. And the same thing would have happened if we consider all these researches to be fruitless, as much as if we consider that fruitfulness is the hallmark of research. If the research has not come out with anything fruitful or successful, it has to be condemned. No. Therefore, if you see all these researches, I am highlighting only a few. The EarthNet, that research was hailed as a landmark research, although there were some deficiencies which were leveled against it because extremes of tidal volumes were compared to a more conventional standard of care. But in the crux, it was a paradigm shift in the ventilation strategy for ARDS patients. Whatever further development unfolded was from that basis. The trick trial changed the transfusion practice. Although the final sample size did not reach the planned target, but It demonstrated that a transfusion trigger of 7 gram per deciliter within a range of 7 to 9 grams has no adverse impact. That was the lesson. It is important to know what message we should take from the study rather than considering literally each and every one lines which is written as the conclusion statement. Nice sugar study. If you see, tight control of blood glucose may result in significant hypoglycemia and worsen clinical outcomes. So it quelled the initial enthusiasm towards maintaining lower blood sugar. So that was the message which came from nice sugar study. The ProSeva study. Most centers today prone ventilate severe hypoxic patients. Came from ProSeva study. Target temperature management post-cardiac arrest. You see, maintenance of normothermia in the post-cardiac arrest is equally effective. The key message that we imbibe from this study were on the basis of which the critical care took forward, went in far future directions. The ANZIX trial showed low-dose dopamine as a renal protective agent. This entire renal protective strategy was shelved into use after this trial. The CRASH-2 trial found that tranexamic acid was not associated with reduction in the transfusion of blood products. That paved the way for other studies to today we are using 4-factor PCC, etc., etc. But we have to understand that it showed a direction in which we moved. The SAFE study showed that albumin resuscitation may be equally safe compared with normal saline unless otherwise specific reasons were there. Adrenal trial. See, the outcome that it message showed that it is the resolution, it reduces the time for resolution of the shock, may not improve the survival. Survival is not the only thing that we look for in the entire spectrum of clinical research in critical care, but there are others. Despite all these, the researchers has been marred with too many criticisms. Why so? Obviously, the reason may creep in our mind. So all these are useless, which is not, it can't be so. Had it been useless, then we would not have moved forward, but we have moved. If we look into this article by Marvin Singer comes very often to India, so we all know him. So in this, he has clearly identified 3 root causes of why these researches are not translating into equitable benefits in terms of clinical service outcomes. If you see, there is disproportionately large number of clinical trials are reported in the high impact journals, but very few novel drugs or interventions which have an impact on the patient outcome have actually been resulted. And treatment strategies based on clinical syndromic presentations like sepsis, ARDS, AKI have always failed short of their initial promise. If you look to the reason why you can see that a lot of research is actually wasted research. When we do a research, significant study, no, it becomes a waste. It is significant, but there is not a low risk of bias. There is a lot of risk of bias. Then again, it is a waste. Circulation in the right format, no, again, it is a waste. So there are a lot of factors which converts, which becomes hidden. And that is why if you see the narrations in this all group of studies which have shown studies conducted in the experimental group showing increased mortality rate may not be an increased mortality rate if we take into consideration the various forms of wasted research. Many a times this wasted research escapes notice and the truth gets buried under it. So what are the barriers in the process of including critically ill patients for research? Because there are a lot of patient-related, next-of-kin-related, researcher-related factors within the domains of context of legislation, research practice, clinical practice, etc., that produces bias. And the most important form of the bias is the attrition bias. The one you choose, the one you try to think, actually they percolate, they filter out, much without lack of our knowledge. And these omitted patients are not a random sample of alleged patients. Therefore, they affect the study outcomes. So what we see is different from what happens. Good number of researches in critical care are registry-based. And whenever research is registry-based, it has inherent shortcomings that we should understand. And those inherent, thank you. Researchers from database need to evolve in terms of analysis protocols. These analysis protocols are not disclosed or deciphered early enough. So unless and until it is expressed in the pre-publication phase of statistical analysis, it does not give the reader that confidence. Many of the interventions that form the core of were introduced from RCTs and the systematic reviews, whereas it can magnify the defects which are there in the original articles. If we look into the data, we will find clearly that longitudinal databases can identify secular trends, but we don't look for the secular trends. We look for outcome-based trends. So the lesson which has learned in recent years is that this database or registry can lead to a loss of waste of time and can also do harm to the patients, but that's what is leading to a lot of studies. If we also look into, one of my friend has cited the example of Prowess shock recombinant. We know that the initial observational study on the droctogravin alpha, that is the recombinant factor, that had shown, 1 minute is left, that had shown an advantage in form of, but it was used in only 4.7% of the patients. That led them to do the Prowess shock study and find its lack of usefulness, and the study was withdrawn to the market. But because the initial research had shown a direction, the final outcome could be ascertained. Therefore, we need to do good quality studies instead of shelving those studies, and we need to find out the right way to know the right answer. A common source of conflict we have always found is the indication bias. The bias arises when I receive a new treatment, like fundamentally different. So if a patient, ICU patient with severe sepsis requires vasopressors, they are already more severely ill. If we had to study outcomes of patients who receive vasopressors against controls in a cohort study, our results typically show that vasopressors are associated with harm. So such studies are of no use. And finally, I would like to also show that it is wrong to think that only randomized controlled study can produce result, because randomized controlled study has a good internal validity, but it has very poor external validity, and therefore it can make wrong even bigger wrong. So they are not always good. And my take-home message would be the results of a clinical research in the last few decades had little to do with the expectations. Our expectations were not met. That doesn't mean that the research were fruitless. This has not to do with the singularities of the critically ill patient, but also with the deficiencies that need to be improved in the clinical chain of research, because this entire process of research stems out from a research question. If there are errors in the fundamental research question, it cannot lead to good research. And the future development of hypothetically precise critical care is promising and should be taken into consideration to reduce wastage. And if any of you have watched this movie, Meet John Doe, Frank Capra's movie, there was a Hindi make of it, Main Azad Hu, Amitabh Bachchan, long back in 1988 or 89. So where Meet John Doe paints the media as a tool of manipulation. So we should not, critical care research should not be painted as a tool of manipulation. And my friend was talking about democracy. If we don't do the research in the proper direction, it becomes plutocracy, that is a government of the wealthy people. Thank you very much. Thank you, sir.
Thank you, Dr. Anirban, for making it very clear. Now we'll move on to the last topic, strategies for cost-effective ICU care for all. I invite Dr. Deepak Vijayan on the stage.
Good evening. Happy to be back at Bangalore with my teachers, Dr. Somanath, Dr. Padma Kumar. It's not uncommon to see such newspaper headlines these days. And we all know that healthcare is getting costlier, and anything which is overpriced is not sustainable. India is one of the countries which spends least on healthcare, because just around 2% of the GDP is spent on healthcare, compared to 18% by the US. But if you analyze the growth of GDP in the last 1 year itself, 1 to 1.5 years itself, there was a 9% increase in the GDP, but there was no proportionate increase in the percentage of GDP allotted to healthcare. So that means the public cannot rely on the government healthcare systems. This is very much true of the intensive care. 70% approximately of the intensive care delivery is by the private sector. But one good advantage is that the insurance is slowly increasing. The insurance coverage is slowly increasing. Now it stands at almost 38%. But most of the insurance is provided by the government, and most of the private healthcare institutes have not subscribed due to various reasons to the government schemes. So this makes the public to pay from their pocket, that almost 56% in 2020 is paid by the patient out of pocket. But as the insurance coverage penetrates, by 2024, the percentage will reduce to 47%. That's a good thing. 17% of the rural and 13% of the urban borrows to pay their bill. And 80% of the rural and 84% of the urban use household savings. That is the savings they have made from working all throughout their life to pay for their hospital bills. Just think how many of the intensivists can pay the care they deliver to their patients. Annually, 60 to 80 million people fall into poverty due to the healthcare expenditure. According to the Government of India reports, there was a 300% rise in healthcare cost, including ICU cost, in the last 10 years. So this is not sustainable, and the government has to do something. So they cap the medical equipments. They restrict the hospitals from making up prices of consumables and medicines from their procurement prices to limit their profits. Coming to the ICU scenario in India, there are 2.3 ICU beds per 1 lakh population compared to 20 ICU beds in US. And 10% of the ICU beds are from the public sector. That is 90% of the ICU beds belongs to the private sector. In South India, as per the 2020 reports, there are nearly 35,000 beds, and in North around 29,000 beds. West 19,000, and in the East around 10,000 beds. ICU care is costly due to the sophisticated hospital equipments and the advanced monitoring systems being used. The skilled workers and the labor-intensive atmosphere, like a 1:1 nursing or a 1:2 nursing. Costly medicines being used, costly antibiotics, costly antifungals, consumables being used. So this makes the ICUs resource-intensive and expensive. Any ICU with less than 6 beds is not cost-effective. An ideal ICU to be cost-effective should have between 10 to 12 beds. Unfortunately, there are not many data on the cost-effectiveness of intensive care. Only few studies on intensive care costing have come from India. Because of the heterogeneous nature of the ICU, like even there is a large cost difference from ICUs in Tier 1 to Tier 2 cities or Tier 3 cities. Or the cost differs from medical ICU, surgical ICU, cardiac ICU and all. And type of illness also, there is a difference in cost. And private hospitals look for profit, and the cost differs according to the profit margin. Only few cost-effective studies in intensive care units worldwide, with an average of 4.6 studies published per year. So we do not have much data on the cost-effectiveness of ICU care to act upon. A significant study done by Dr. Peter and J.V. Peter and team at CMC Vellore concludes that in 2/3 of patients admitted, family earnings per annum was less than the total medical cost of intensive care, and families were willing to pay only 53% of total treatment cost. This actually many times results in conflicts in the ICU, where the patient is ready to pay only 53% of the bill. The rest 47% has to be written off or subsidized. The objective for for-profit private healthcare will be to make a profit and to disperse returns to its investors and invest in further growth and development. while the objective of the public healthcare provider would be to provide equitable services that benefit the maximum number of people at the lowest cost. That means for government, intensive care is not going to be a priority. For them, communicable disease will be a priority, chronic health problems will be a priority. But intensive care, because of the resource intensive nature, will not be a priority for the government sector, at least for in the coming few years. The result is that the patient has to bear the cost of healthcare. And this high cost of healthcare are attributable in part to overuse of tests, treatments, and procedures that provide little to no benefit for patients. So standardization is very important in reducing the cost. Let us look at this study by Garland, which is an important study. And they observed that there is a large difference among intensivists in the amount of resources they use to manage critically ill patients. It appears possible to reduce cost-inefficient variation by efforts to promote consistency of care across physicians. If we look at ourselves itself, one intensivist may be ordering blood tests regularly or maybe ordering more diagnostic investigations. So I think in such cases, the standardization or protocolized management is very essential. A consensus statement by the American Thoracic Society, Society of Critical Care Medicine, and the American College of Chest Physicians made a top 5 priority list to act upon to reduce the cost of ICU care. The first one is do not order tests at regular intervals, that is CBC electrolytes daily. No need of that. Rather, in response to specific clinical questions, only these tests should be ordered. Do not transfuse RBCs, especially in surgical ICUs and all, this is being misused. Do not transfuse RBCs in hemodynamically stable, non-bleeding patients with hemoglobin greater than 7 grams. Do not use parenteral nutrition unless absolutely indicated, because it is costly. Do not deeply sedate mechanically ventilated patients without specific indication. And do not continue life support for those at high risk of death or severely impaired functional recovery. So these are the 5 priority lists put forward by the consensus statement of the various societies. And this is a consensus statement by various professional societies. And one of it is to maintain the competency of staff. By maintaining the competency of staff, we can avoid errors which adds to the cost. So consideration should be given for ongoing personal performance evaluation plan for each physician and end of year evaluation. So now the hospitals are thinking, because of the pressure from the insurance company on pay for performance, that in the coming few years, I'm sure that they will assess the performance of the physician and then they will pay for him. Multidisciplinary care model has been shown to reduce the cost of care. A review article which reviewed 21 articles between 200 in the last 10 years have shown that multidisciplinary care improves clinical outcome and reduces the mortality rate, improves communication among the group and also with the relatives, and reduces the length of stay. And the Society of Critical Care Medicine has put forward that $13 million have been served in annual hospital cost savings by implementing the multidisciplinary care. Another important thing is the length of stay. Avoidable time accounted for 12.8% of the total ICU beds. That is, delay in shifting out of the ICU. And 6.4% of the total ICU cost was attributed to this delay in shifting out of the patients. That may be due to many reasons, like they do not have a proper HDU or they do not have the resources to monitor this patient outside the ICU. So development of step-down ICUs or long-term care units could be an answer for this. In UAE and in many Western countries, they have the long-term weaning units where long-term ventilator patients are shifted. And this definitely reduces the cost of care. Tele-ICU is an important thing which can reduce the cost, and it reduced the length of stay also by 36% and a cost saving of 11.5 million. And this is another important thing, that rather than a rota-based staffing, an activity-based dynamic staffing will help in reducing the cost of care. And this is an important study, the economic implications of nighttime attending intensive coverage in a medical ICU. This is applicable only to the university hospitals. In a secondary care, secondary level hospital, I think round-the-clock intensivist is going to increase the cost of care. But in a tertiary level ICU, that is definitely going to reduce the cost of care by improving the outcome. And another important thing is the early mobilization, which also causes a 29% reduction in substantial costs. Next important thing to be considered is the green ICU concept, where you stress on the 4 Ps, that is, use fewer products, use better products, achieve more with less, elimination of the waste and lean management, improve upon your people, and reduce and recycle whenever possible. Artificial intelligence is also an important application in ICU which can reduce the cost. To conclude, excess demand relative to supply means not all essential interventions can be funded. Measuring longer-term patient-centered outcome is important to get resource allocations. Using quality-adjusted life year is important factor in cost saving. Efficient use of resources and focusing on interventions that reduce cost and minimize avoidable cost would translate to improved outcomes and cost savings. Thank you.
Thank you, Dr. Deepak Vijayan. Now the floor is open for questions. Before that, I would like the chairpersons to give a few take-home messages for the topics we have discussed.
Thanks for the excellent talks. I'm glad that people who stayed would have enjoyed it. The speakers were really highlighted quite relevant and interesting points. In a way,